Welcome to The Explainer. Today we're diving deep into the fascinating microscopic battlefield of liver disease. We're going to figure out exactly how our body's most resilient, incredible organ can literally be pushed past the brink. The liver is an absolute powerhouse. It's down there performing hundreds of essential functions every single minute, from filtering toxins out of your blood to synthesizing vital proteins that keep you alive. But what actually happens when this amazing regenerative machine is subjected to relentless chronic injury? Well, today we're going to explore the pathology, the clinical manifestations, and the devastating systemic consequences of cirrhosis and hepatic failure. Now, whether you're reviewing these critical, high-yield concepts for your United States medical licensing exams, or you're just a focused learner eager to understand human pathology, you are in the right place. This explainer is designed to distill the most crucial, must-know information directly from the source material, so let's get right into it. Here is our game plan for today. We'll start with 1, the case of liver cirrhosis, move into 2, the anatomy of a damaged liver, tackle 3, the portal pressure problem, and then trace 4, the systemic domino effect. Finally, we'll cover 5, staging and diagnosis, and contrast it all with 6, acute liver failure. Section 1, the case of liver cirrhosis. Let's meet our patient, Mark Letterman. To really anchor this, let's look at Mark. He presents with a classic medical mystery that points directly to severe liver damage. He's a 52-year-old guy with a known history of hepatitis C, and he's complaining of progressive abdominal distension over the last 10 days. His belly is just swelling up. Now, his lab results reveal several immediate red flags that you absolutely need to recognize. First, his liver enzymes, AST and ALT, are elevated at 95 and 79 respectively, which tells us there is active, ongoing hepatocyte damage. Then, an ultrasound reveals his portal vein diameter is 14.6 millimeters. To put that into perspective, that is well above the normal threshold of 13 millimeters, so we've got some serious pressure building up there. Furthermore, the doctors withdrew this straw-colored fluid from his abdomen via paracentesis, revealing a serum ascites albumin gradient, or SOG, of 1. When you take all these clinical clues together, the viral history, the elevated enzymes, that enlarged portal vein, and the fluid buildup, they paint a crystal clear picture of liver cirrhosis with portal hypertension. So what's causing all of this across the population? Looking at the major etiologic factors in the U.S., hepatitis C leads the pack, accounting for 26%, so over a quarter of all cases. Right behind it is alcoholic liver disease at 21%. And then we have non-alcoholic fatty liver disease, or NAFLD, coming in at 18%. Actually, it's really important to note for your exams that many cases previously labeled as cryptogenic, meaning we just didn't know the origin, are now understood to be driven by NAFLD. These 3 major players account for the vast majority of patients currently sitting on the liver transplant list today. Then, you've got combinations like Hep C plus alcohol at 15%. Finally, rounding out the rest, are the less common but highly testable causes like autoimmune hepatitis, primary biliary cholangitis, Wilson's disease, and hemochromatosis. Now, before we dive into the microscopic changes, we have to establish the crucial distinction here, the point of no return. Fibrosis and cirrhosis are not the same thing. Fibrosis is essentially an excess deposition of extracellular matrix, like collagen. But in fibrosis, the underlying lobular structure of the liver remains intact, and because of that, it is remarkably, potentially, reversible if you can just treat the underlying cause. Cirrhosis, on the other hand, is a totally different story. It's a diffuse fibrotic process where that normal, beautiful lobular parenchyma is entirely ripped up and replaced by structurally abnormal regenerative nodules that are separated by thick fibrous septa. Once the liver reaches this stage of widespread diffuse structural deformity, the process is completely irreversible. Section 2, Anatomy of a Damaged Liver. Let's zoom into the microscopic battlefield. Depending on the specific disease process at play, the liver forms completely different sizes of these fibrous nodules. And this is a massive buzz point for exams. Micronodular cirrhosis features these tiny uniform nodules that are less than 3 millimeters in diameter. When you see this, you should immediately be thinking of alcoholic or biliary conditions. Contrast that with macronodular cirrhosis, which presents with regenerative nodules that are highly variable in size, mostly larger than 3 millimeters, with these wide, irregular scars. This specific pattern is strongly associated with chronic viral infections, just like our patient Mark's hepatitis C, or conditions like alpha-1 antitrypsin deficiency. And just as a side note, it's actually quite common for a micronodular pattern to slowly evolve into a macronodular one over time. Okay, let's talk pathogenesis. This step-by-step chain reaction is incredibly high yield. It all starts with hepatocyte parenchymal loss. the liver cells start dying off. This death and inflammation trigger the true villains of this story, the hepatic stellate cells. Normally, these cells are just chilling out, quietly storing vitamin A, but injury transforms them. They activate into myofibroblasts, migrate to the damaged areas, and just start pumping out massive amounts of type 1 collagen. This collagen forms active fibrotic septa, literally building walls and dividing up the liver. Meanwhile, the surviving hepatocytes are desperately trying to multiply to replace the lost functional mass. They create these hyperplastic regenerative nodules, but because of all that scar tissue, they end up entirely trapped within these newly formed fibrous walls. As this architectural nightmare progresses, the underlying scaffolding just completely collapses. When those healthy cells die off and drop out, notice how the central veins and the portal tracts, which in a healthy liver are well separated by functional tissue, are pulled dangerously close together. The delicate reticulin stroma collapses, forming passive septa. And when those activated stellate cells lay down all that type Y collagen, these septa actually contract. The end result is a highly abnormal, deformed vascular architecture. The normally fenestrated liver sinusoids, which usually have little gaps to let stuff through, lose their gaps and become rigid, continuous capillaries. This is a process known as sinusoidal capillarization. This completely ruins oxygen diffusion and drastically increases resistance to blood flow.
Section 3. The portal pressure problem. Time to look at the traffic jam.
So, because of all that capillarization and scarring, blood flow is blocked and we get portal hypertension. Normally, portal venous pressure is hovering around 5 to 10 millimeters of mercury. When it rises more than 5 millimeters above the inferior vena cava pressure, boom, we have portal hypertension. We clinically classify this based on exactly where the blockage occurs. Pre-sinusoidal blockages happen before the blood even enters the liver's functional units. Think of conditions like portal vein thrombosis or schistosomiasis. Post-sinusoidal blockages happen after the liver, such as in right-sided cardiac failure or Budd-Chiari syndrome. But cirrhosis is the absolute classic primary cause of sinusoidal obstruction. Those fibrotic nodules and contracted stellate cells literally squeeze the life out of the liver's microcirculation right in the middle of the pathway. Section 4. The systemic domino effect. Let's see what happens to the rest of the body when the liver fails. This flowchart beautifully explains Mark's distended abdomen. End-stage liver disease causes intense intrahepatic vasoconstriction, which skyrockets the portal pressure. But, paradoxically, this localized high pressure causes splanchnic arterial vasodilation, meaning all the blood vessels in the gut open wide up. This massive pooling of blood drops systemic vascular resistance and severely reduces the effective arterial blood volume. So what does the body do? The body panics. It thinks you're bleeding out. It activates the renin-angiotensin-aldosterone system to aggressively retain sodium and water in the kidneys to try and boost blood pressure. Now, combine all that extra fluid with hypoalbuminemia because the failing liver can't produce enough albumin to maintain osmotic pressure, and all this fluid has nowhere to go. It leaks directly out into the peritoneal cavity. And that, my friends, is the pathogenesis of ascites. But the fluid isn't the only problem. Because the main vascular highway through the liver is blocked, the blood still has to find a way back to the heart. It essentially reverses flow and forces its way through tiny, normally closed collateral vessels, causing them to balloon outwards into dangerous detour veins. The most perilous of these are gastroesophageal varices. These form a bridge between the portal left gastric vein and the systemic azygos vein. They are present in about 90% of cirrhotic patients, and they carry an incredibly high risk of massive, fatal bleeding. We also see umbilical anastomoses creating what's known as the caput medusa, those engorged, snake-like veins radiating away from the belly button, as well as rectal anastomoses causing viruses down in the lower GI tract. Now, if the liver isn't filtering toxins from the blood, those toxins just circulate freely. And one of the most dangerous is ammonia. Normally, a healthy liver converts toxic ammonia from your gut into harmless urea. But in cirrhosis, that ammonia completely bypasses the liver through those portosystemic shunts we just talked about, and it travels straight up and crosses the blood-brain barrier. Inside the brain, your astrocytes try to help out. They attempt to detoxify the ammonia by converting it into glutamine. However, this glutamine accumulation acts exactly like a sponge. It draws in huge amounts of water, causing massive astrocyte swelling and cerebral edema. Clinically, this invisible brain swelling manifests as very visible, testable, physical signs: profound personality changes, a distinct flapping tremor with outstretched hands known as asterixis, and eventually a severe alteration in consciousness or even a coma. And I'm telling you, it doesn't stop at the brain. That altered blood volume we talked about earlier essentially starves the kidneys, triggering hepatorenal syndrome.
Due to that extreme splanchnic vasodilation, the kidneys experience intense, desperate vasoconstriction to try and maintain blood pressure, which eventually leads to profound renal failure. The dominoes just keep falling. The failing liver can't process estrogen properly anymore, leading to hypogonadism, spider angiomas on the skin, and palmar erythema, red palms. It stops producing vital clotting factors, creating a severe coagulopathy that makes any bleeding diaphysis incredibly difficult to manage. Even the lungs are affected, with hepatopulmonary syndrome causing severe hypoxemia. The systemic failure is just absolute.
Section 5. Staging and Diagnosis. Let's look at the timeline of cirrhosis.
The natural history of cirrhosis is basically a ticking clock. It moves from a long, silent, compensated phase to a rapid, highly dangerous, decompensated phase. In stage 1 and 2, the patient is compensated. They might have literally no symptoms at all, or they might have varices that just haven't bled yet. The body's managing the workload, it's compensating, but the pivot to decompensation is stark. By stage 3, ascites appears. This is a huge milestone, often the very first visible clinical sign that the liver is finally losing the battle. By stage 4, those varices we talked about are actively bleeding. Once decompensation occurs, survival rates drop precipitously. And while imaging and lab tests offer us great clues, a liver biopsy remains the absolute gold standard for definitive diagnosis. Often this is done transjugularly, going through the neck veins, specifically to avoid puncture bleeding risks in these highly coagulopathic patients.
Section 6. Acute liver failure. Let's look at a sudden contrast.
Before we wrap up, we have to build a crucial clinical contrast for you. While cirrhosis takes decades of smoldering damage to develop, acute liver failure strikes a previously healthy liver with sudden, massive tissue death. By clinical definition, acute liver failure, or ALF, is severe acute liver injury accompanied by encephalopathy and a prolonged prothrombin time in a patient with absolutely no pre-existing cirrhosis or liver disease. It's a completely different beast, a totally different clinical trajectory. There is no slow scarring here, no gradual nodule formation. Instead, it is characterized by rapid, massive destruction of the liver parenchyma, which leads almost immediately to catastrophic multi-system organ failure. Alarmingly, nearly half of all acute failure cases in the United States are caused by something you can buy over the counter. Simple acetaminophen overdoses are responsible for 46% of these cases. Pathologically, if you look under a microscope, this presents as massive central-lobular or pan-lobular hepatocellular necrosis. The liver is literally shrinking rapidly as cells die en masse. Because the failure is so incredibly sudden, the body has zero time to compensate. Patients rapidly develop severe cerebral edema, intractable coagulopathy, and circulatory collapse that mimic septic shock. They also have a uniquely high susceptibility to bacterial sepsis. Despite modern intensive care, the mortality rate hovers around a grim 40%, making emergent liver transplantation often the only definitive lifeline available. So let's bring it all together. Our liver is incredibly resilient, but as we've seen today, once that delicate architectural balance is broken, the whole system just collapses with it. We've traced the microscopic cascade from stellate cell activation to irreversible nodules. We've examined the systemic devastation of portal hypertension and encephalopathy, and we've contrasted chronic cirrhosis with the sudden, catastrophic nature of acute failure. Understanding these testable mechanisms reveals the sheer, terrifying complexity of our biology. Given the liver's incredible regenerative power, it leaves us wondering, how can modern medicine eventually learn to reverse this seemingly irreversible scarring before the clock runs out? Thank you so much for joining us on this deep dive into the source material. Stay curious, keep exploring, and we'll see you in the next explainer.